Good morning, or good afternoon, or maybe even good evening, depending on where you are. And welcome to our global viewpoint discussion for where we're going, healthcare. I'm Dolly Duffy, the Executive Director of your Notre Dame Alumni Association, and I can't tell you how happy I am to be with all of you today. Last week, for those of you who were here during our National Viewpoint segment, we heard from some Notre Dame alumni living here in the US and leading initiatives that are helping both their local communities and around the world. Both of our speakers, Peter Banco from the class of 1989 and Jane Lee, a Domer Dozen honoree and alumna from the class of 2009, both talked about the impact that this pandemic has had, not just physically, but as a society. And Jane said, quote, "The COVID-19 pandemic has really shed a light on all of the inequities that really characterize our society and our nation." Peter agreed, saying, quote, "This virus has a great way of spotlighting your weaknesses organizationally, systematically, and personally from a leadership perspective." These are two outstanding observations from two of our amazing alums. And I think we can all agree that this shared human experience of this pandemic has definitely challenged each of us in more ways than just physically. Joining us today for our discussion are guests from the United Kingdom and Kenya. I'm so excited to hear their perspectives and insights on healthcare from their vast experiences all over the world. But before we welcome in our guests, please remember that if you have questions for our speakers, you can use the Google form that we are sharing with you now. And please know that we're going to try to get to as many of your questions as possible. And now I'd like to welcome back our moderator for this really great healthcare series, Dr. Bernard Nolan, an alumnus from the class of 1975 and the current director of Notre Dame's Eck Global Health Institute. But Bernard, before I turn the conversation over to you, as always, I have a question to ask. Throughout your career, you've seen a variety of healthcare innovations. What trends are you seeing now that really give you the most hope?
Thanks, Dolly. That's a great question. We're going to be talking about some of these innovations, I think, as part of today's panel. There's obviously tremendous innovations on the sort of product development side, whether it be new drugs or diagnostics, or we see it in our own time, in real time, the COVID vaccines, and the fact that within a year we have really great vaccines. The challenges, and I think where some of the innovations that I'm excited about are, once you have these new tools for fighting diseases, how do you actually get them out to people in remote areas who are maybe at the highest risk for these diseases? And how do you go about doing that? I think there's a couple of things going on now, which I've seen over and over again in lower income countries that are pretty exciting. One is the explosion of mobile technology. So now you can actually call out to remote areas. You can actually transmit health messages. Healthcare workers in more remote areas can actually communicate back to the central health facilities. And then just delivering these goods out there. Some really exciting stuff going on in several countries using drone technology. So you no longer have to rely just on your regular roads, which are frequently inadequate, but using drone technology to actually deliver goods in very remote areas. And last but not least, I think there's now much more serious partnership with local communities. So, local folks in villages can actually play an important role when it comes to healthcare messaging around prevention, but also in actually delivering services. And there's lots of examples of that going on now in lower income countries, which I'm really excited about. And I'm also excited to welcome our two panelists today, Dr. Brian Donley from the Cleveland Clinic in London, and Dr. Juliana Otieno, who's the former CEO of Western Kenya's largest teaching and referral hospital, and also the founder of the Rusalia Foundation. So to get us started, I'd just like Brian and Juliana, for each of you to share a little bit about your Notre Dame story and how it led you to the work you do today. So Juliana, let's start with you.
Thank you very much, Bernard. I'm really happy to be in the panel today, and I want to say good morning, everybody. I'm a medical doctor trained in Kenya. I worked in Kenya in the public health sector for 34 years before I retired. And by then it was the only medical school in Kenya for a very long time. I'm happy, and I was also privileged to be an alumni of ILI, that's Inspired Leadership Initiative Program at the Notre Dame. 2020, that was the second cohort. That's where I met many most important people. And Bernard, who has been a friend for a long time, still remains my friend and my colleague. But I want to say the experience I had in Notre Dame, really, joining classes, attending classes with the undergrads and the postgrads was quite an experience I'd never felt. And it was an eye-opener because I had time to attend philosophy. You know, there's some topics or areas I just heard about and had never really taken quite in depth. So I was privileged to attend the philosophy class, the Inspired Designing an Inspired Life. You know, we had this great speaker who was like, don't think you have retired. You are in the process of refiring. So after 60, in Kenya, people retired at 60 years old, which still really is not that old. I hope I don't look so old. And this great man was like, you are refiring, not retiring. I was also privileged to meet Professor Steve Reifenberg, and of course, Bernard, and many other people. And my ILI fellows were a group of 15. They really inspired me to start what now I'm also spending time on Rusalia Resource Foundation. This is a foundation supporting young girls to attend high school, providing for them tuition fees, uniform, books. Those are simple things that we take for granted, but we have some bright girls out there in the world who just lack some of these things. So I think in a nutshell, that's my story. Currently, I'm a teacher, I'm a lecturer at one of the Catholic private universities in Western Kenya. It's called Uzima. Uzima means health. I'm lecturing in the Department of Pediatrics and Child Health. That is my subspecialty. So thank you so much.
Thanks, Juliana. Brian, over to you.
Yeah, thanks, Bernard. And thanks for the opportunity to be here and talk with you and Juliana and the audience. You know, when I hear Juliana's story, the influence of Notre Dame, there's a lot of similarities when I think of my experiences, and that revolves around the people at Notre Dame. I am the youngest in my family. My two older brothers went to Notre Dame. I graduated from Notre Dame in 1986. And after that, went to Michigan for medical school and for orthopedic surgery training, and then joined the Cleveland Clinic. I think the influence, as I've thought more and more about this, as I've gotten older, the influence of Notre Dame is the fact that it created an environment, which I still think exists today, around service for people. And it was a unique experience to have 4 years with a group of incredible, high quality human beings who had a focus around service for others, had a focus on excellence, and had a focus, you know, you could say, on kindness or caring. You know, the two people that were really influential, actually, coincidentally, I met on my very first day at Notre Dame. When I was at Dillon Hall, randomly put there as a freshman, and my random roommate shows up, and it's a person who I lived with for 7 years, who went on to medical school and now is the chair of plastic surgery at Boston Children's Hospital and a leader in global surgery with Partners of Health and a chair at Harvard. And that's a gentleman named John Mira. You know, and so what an influence to have 7 years with that. That was my first day. And then my third day, I met potentially probably the most empathetic human being who has a care for others and a culture of an environment for servicing others like I've never met. And that's actually my wife. I met my wife on my third day. She lived in Lewis Hall. She actually displaced John as my roommate 7.5 years after we got married. So I've actually only lived with Notre Dame people ever since I was 18.
Thanks, Brian. Those are great stories. Juliana, could you say a little bit about, I mean, you're a pediatrician and former director of the provincial hospital in Kisumu. And so you've been an integral part of the medical community in Western Kenya for decades now. Could you just say a little bit about what impact you've seen the COVID-19 have on the Kenyan healthcare system up to this point?
Thank you very much. I just want to say that in Kenya, our health income, all the healthcare percentage that the government gives to the healthcare is less than 15% of the WHO. In fact, it's less than 9%. So when the COVID-19 came in, really the resources were already overstretched and there was redistribution. Money's finances were pulled from other areas to start fighting or combating the COVID-19. Kenya is still grappling with communicable diseases like diarrhea, pneumonia, malaria, TB, HIV/AIDS. And those are conditions that if we don't continuously continue taking care, people will either get resistance or death, mortality will increase. So that care of these diseases were actually, COVID kind of replaced the care of these diseases, which is very unfortunate. So we are seeing more cases of diarrhea, and we're seeing more cases on the rise of tuberculosis. Of course, when the patient is COVID tested, COVID-19 positive, we are going to say the cause of death is COVID-19, but maybe it was really the TB that killed this person. Also very sad that immunization also for children was kind of also sidelined because of the scare of the COVID and the way it was, the health messages that were being passed. And there was also the lockdown in the country. Movement and going to the facilities was very difficult. It was really, the care for the COVID-19 patients was in the public facilities in the beginning. The private healthcare started bringing on board later on. So the public facilities were overwhelmed. So there was kind of removing some wards or redistributing, restructuring, putting up new hospitals, new facilities for this. And that kind of also eats up the little money that we had. Unfortunately, during the COVID-19, we had several healthcare workers strike. So what did the government do? They actually brought in doctors and nurses on locum to take care of the COVID-19 patients. There was also, the disbelief, the messages that was being passed. I'm happy to say that our Minister for Health and the President was really on the forefront to kind of, pass the message and to make us know that things were not that bad. But what I'm saying is the other conditions, management, chronic conditions, acute conditions that we have were really neglected. We were all zeroing down on COVID-19. Some hospitals were closed and they were turned into COVID-19 centers. So even mothers could not deliver into those facilities nearest to them. So that's what the government did. And the resources was kind of redistributed to take care of the COVID-19. Thank you.
Thanks, Juliana. Some of what you're seeing in Kenya certainly resonates with some of the challenges we've seen in parts of the United States as well. Brian, you've been a hospital administrator. I've been involved in hospital administration in both the US and the UK. Could you say a little bit about what major differences you've noticed and experienced in your move to the UK?
Yeah, sure, Bernard. It's been actually a great experience, and all of us, I think, talk about different silver linings that we found during this pandemic. One of several of those for me is actually to have had the opportunity to be here in the UK during this time, to really be able to compare and contrast, the strengths in the US health system and the strengths here in the UK health system, and to be able, for what we're trying to do here at Cleveland Clinic London, try to combine those together to build a new model of care. Certainly, not just in the pandemic, but overall, what you see some of the great strengths in the NHS, National Health Service here in England, is the advantages of centralized decision making. A decision can be made and it goes instantly across the country. And that for the pandemic, that can be around masking, social distancing, but it also has to do with public health measures and processes within healthcare. And that's certainly an advantage. The other advantage you see in the UK is around the national database for research and for education. And an example of that during this pandemic was early on, still exists now, but early on, huge advantage to have all the patients in critical care in the ICUs and be able to collect all that data on all admissions across the country, opposed to in the US, we see different health systems with their data and try to aggregate that. And that's certainly a strength, I think, here in England. I will tell you from the US standpoint, what we hear a lot about and some of the big interest in Cleveland Clinic here is around our experience and our success with innovation. And I think you highlighted it in your opening comments, that innovation is not in and of itself what's important, but it's only really important when you can deploy it at scale. And I think that's a real advantage that we have in the US, and that's around a culture of innovation, fostering it, but then being able to deploy it at scale. And I'll just end by saying, there's different strengths in the systems, but the one commonality that I have seen, and in many ways across the world, is the one commonality is the passion for others that healthcare workers have. And that you see that, and you saw it better than ever during this pandemic, the deep, deep passion for another human being that exists in healthcare.
Thanks, Brian. Juliana, going back to COVID-19, which has had such a, again, challenged an already underfunded healthcare system in Kenya. So does the government of Kenya, what has the government of Kenya done to address the COVID-19 pandemic? Is there any plans, for example, to roll out the COVID-19 vaccine? And what are some of the major challenges you think are ahead?
Thank you, Bernard. We are happy this time, at least there was the political will. Our president and the Minister for Health were really on the forefront. So the WHO guidelines were being followed, and it was the president who was advocating for them. We also had the lockdown, and it was also involving the international. It was not just the national borders, but it was also international borders, especially with our neighbors, Tanzania and Somali. Unfortunately, some Tanzania border is still closed, and that affects some of us who have relatives in Tanzania. Western Kenya is very close to Tanzania. And there was really the provision of the PPEs, personal protective gears to the health workers. These were mainly to the public facilities. So when the private health facilities, patients were being taken to, I think there was a bit of outcry because they also needed support. The other thing that was not very good was the insurance companies refused to fund or pay for COVID-19 hospitalization. So that was quite a disaster. The government also had the social economic support to the underprivileged. This was the elderly, people who are out of employment. There was a criteria the government was using, and this was both for people in the cities and people also in the rural areas. It's important to note that people in the cities tend to support people in the rural areas. So if the people in the city are not having economic sustainability, then the people in the rural areas are also going to suffer. So the government, in as much as they were supporting the people in the city, there was also support for people in the rural areas. And I think the COVID-19 vaccine rollout, the plans, this one I had to consult with the national team so that I say the correct thing. The plans of rolling it out were out, is still on schedule. Unfortunately, 2 weeks ago, the media had a public publicity that it will now not be rolled out as planned. It will be done in 2023. And that really, made us health workers very unhappy. But the government has reassured us the vaccine rollout is still on schedule. It's on 24th. It's in March this year. And we hope the government now is just in the preparation of rolling out. And remember, we still have challenges, infrastructure, in terms of roads, transportation, accessibility. So rolling out the vaccine, and it is being planned for healthcare workers first, and the people in the front line, like the police, the security, and all that. But we are worried of the people in the healthcare workers in the private sector, because it's like the government is not thinking about them. And that may bring a challenge. And if the private sector decides to import the vaccine, then the cost of the vaccine may just go up again, and that will be really disaster for the country. So we hope that it will still be rolled on time. We are foreseeing a few challenges with the rolling out of the vaccine. Unfortunately, there's been a lot of rumors and bad things about any vaccine that comes in. Any new vaccine that comes into Kenya, we always have negative publicity, and COVID-19 vaccine is not immune to it. And the worst rumor is it is laced with family planning. So when people get it, the women will become barren, the man will become sterile. So those are rumors that really must be allayed. And unfortunately, we sometimes have key people in the church and politicians who speak about that. And that really must be, we hope it will not go on for, unfortunately, so that it derails the provision of the vaccine. We also have fear. The challenge is also the quality. Our quality in terms of the national quality control and the pharmaceutical quality control is not tight. There's weakness, there are loopholes. So we are wondering if we'll really get a good vaccine. The other challenge is the cold chain. If we get a vaccine that needs to be kept in the fridge, most areas don't have electricity. What will we do? And that's something that we have to think about. But I think the government is working around that to find a way of probably dealing with that. What I may foresee is in the big cities, because if they're starting with the health workers, they may actually have a center where the health workers could be coming to get the vaccination, and then they go back to their peripheral areas of work. We also have the community health workers. So I don't even know whether they are also part of these health workers, because sometimes when we talk of the community people, we think of them as non-skilled. They don't touch patients a lot, but they do deal with a lot of patients in the community. So that's something, food for thought. Thank you.
Thanks, Juliana. Certainly your comments about misinformation and vaccine hesitancy, I think, are not specific to Kenya. Certainly here in our own country, we're dealing with similar challenges. Brian, you're building a new hospital in London, and we'd love to hear about it and the new innovations that the Cleveland Clinic is bringing to London.
Yeah, thanks, Bernard. We're building in London. We're still in the process of building it. My wife Mary and I moved over here about a little over 2 years ago, and the Cleveland Clinic purchased a building behind Buckingham Palace. We tore that down, and now we're in the process of building a 184-bed hospital with 29 ICU rooms, and it's planned to open in 48 weeks. But what we're doing is we're really conscious in talking about the fact we're not bringing the Cleveland Clinic to London. We're bringing the best of what we do, and we're integrating with the best of UK healthcare. Because as we bring those ideas together, as we mold some of that culture together in the best aspects of it, that's the new model of care that we want to develop. And then we can take that learning and spread that back across the organization. This will be a hospital that has a focus on complex interventional care. It is similar to what we do in Cleveland from a historical standpoint. And so our flagship clinical institutes are cardiology, cardiac surgery, orthopedics, digestive disease, and neurosciences. It will be a full service hospital here, but those will be for the institutes that we concentrate on. And along with that, we will bring a heavy digital focus and plan for this to be the most digitally advanced hospital in the UK. And we do that because we feel that that's one of the most important ways to drive better quality, better experience of care, and better safety of care. And just one of those innovations is we'll bring a closed loop medication ordering system to the UK, which will be the first digital dispensing system here in the UK. And we will do that around the electronic medical record. We will barcode every single dose of medication and then have a robotic system to pick those medications, bring them up to the patient so that the patient's wristband is scanned, every medication scanned, and then matched with the order in the electronic medical chart. And we do that again around safety. The whole purpose is to drive down medication errors, as we know can be a common source of problems and expense to the healthcare system. That's just one of the innovations that we'll be bringing to the UK. But again, I think the real important point is it's an opportunity, and the number one reason why we made this investment is for us to learn and innovate and be better. And we're proud that we're celebrating as a Cleveland Clinic our 100-year centennial actually this week. And we're here to try to be great for our patients for another 100 years. And that's why we feel that coming to learn and innovate with others is how for us best to do that. And I can tell you just a short time sitting here on this call, and hearing Juliana talk, it's phenomenal to hear the problems that she faces and the great solutions that she thinks of, that her team thinks of, and the people of Kenya think of. Those are things that can be learned across the system.
Yeah, Juliana, you had your hand up there, I saw.
No, it's okay. There was a child who was coming into my room.
Oh, okay.
Yeah, but I think what Brian has said is really right. Let me say, in Kenya, we are still, the digitalization is not uniform. Private sectors is way ahead. Public sectors is behind, and it all comes down to finances and priority. Unfortunately, some of our leaders never thought digitalizing the health records and patient care was not important. So that's the challenge that we have right now. So even in the largest hospital where I've been, I think I'm the one who initiated the digital seeing patients online. And that was like 2011. I mean, it's crazy, and it wasn't taken politely. People are just saying we are misusing the funds for things that are not very important. But I think having patients' care notes or whatever it is on a digital platform is really useful for sharing with other people and for consultation.
Juliana, are there any other innovations you see going on in Kenya that we might learn from? I'd mentioned, for example, the fact that now even in remote parts of Kenya, there are mobile phones. You can actually communicate in a way you couldn't before. And other ways of being able to deliver services that people have experimented with, and some of which has been scaled up. I just wondered if you could say any other innovations you've seen in Kenya during your career in healthcare that you think have been game changers.
Yeah, I think mobile phone has really kind of revolutionized care for people and also for the community health workers. We use the community health workers for patients follow-up. Remember I said we still have lots of communicable diseases that really people must go to the community to assess the conditions and help the people deal with the issues they are having. So mobile phones, a studies done about 2 or 3 years ago that over 90% of Kenyan households, at least one person has a mobile phone. So that is good. It may not be a smartphone, but at least you can pass a message. Hey, your clinic time is due. You are late for your clinic. And we use it a lot for malaria cases and TB, HIV follow-up, contact tracing, HIV care, reminding patients of when to come for their care. For the last almost 10 years, immunization coverage for children in Kenya was really going down. And we have what we are calling lost to follow-up or missed opportunities. So 5 years ago, that mobile phone was being used to kind of help remind the mothers that because the last vaccine from 14 months, the next one was 9 months. But right now, I'm happy to say that we have malaria vaccine, we have the rota. So the mother is currently coming to the hospitals until 6 months. Then from 6 months to 9 months, there's a break. But the break is much shorter. So that mobile phone was quite useful. The good old telemedicine that you guys enjoyed for a long time is still not yet, not yet taking root part in Kenya, but I'm happy to say that it is improving. And with this COVID-19 of the lockdown, most universities, most teaching hospitals were actually using the telemedicine. And in the hospital where I worked, we have what we call the ECHO project. This is extension for community healthcare outcome. This is a program or a project that was started at New Mexico, Albuquerque. And it was brought to us in Kisumu by the ICAP of Columbia University. It is for patients with HIV and TB. The good thing is we have a center where we have the experts, and we strengthened the peripheral facility, which is a larger peripheral facility where the healthcare worker can actually have the patient's notes. And if they can't understand or they need consultation, we just use ECHO, and we are able to talk the way we are Zooming right now. And we are able to discuss the patient conditions. Long time ago, before that, we would refer the whole patient without the notes because the notes was not mobile. So that ECHO has made our work much, much easier and better. I'm happy to say in Rwanda, they're using the drone. They were even using the robots to care for, to deliver drugs and to care for patients in the highly infectious, hospital. In Kenya, we don't have the drone and the robots yet, but we still use the good old, I think the good old mentorship, our coaching, because the hospitals can be quite far apart. So you have a team of healthcare workers that can come to this specialist, or we have one specialist going out to the remote areas to take care. That is being strengthened now in Kenya because transport and the specialists don't have time even to teach currently in the local hospitals. We also have the other innovations in surgery. I remember our hospital had the first laparoscopy after Kenyatta National Hospital. And only one doctor was trained to use laparoscopy for gynae operation. And after the doctor resigned and left government services and went private, that gadget was just kept for the next so many years until now retraining. So we still have some old innovations which can be improved. And I really think that there are also newer things that are coming. The information technology, digitalizing patients' records is really one thing that needs to be strengthened. Thank you. Brian?
Bernard. Yeah,
Sure, Brian.
Maybe I can just make a comment on that. I think it's really important, and I think most of this audience is probably US based. I think it's really important to listen to Juliana's answer there. And it's important, I think it's important, not because it's interesting, but it actually helps us with innovation and helps us solve problems. When you started, Bernard, at the beginning of this, you talked about some of the challenges, and you're hopeful how remote areas can get more services and more medications. But remote areas also exist in our cities of 10 and 20 million people here in the US. There's food deserts, there's housing concerns, there's this very similar challenges. And when I listen to Juliana and I look at the work in Rwanda around drone delivery of medication supply, these are innovative solutions that we need to look at and how we can adapt those to help solve our problems. And I think it speaks to your earlier question about innovation and what fosters innovation. And the things I think that are really important around that are the words of curiosity and humility. And I think you can't really have good curiosity without humility. And those are important, but also having a diverse input. And that's why innovation, especially in healthcare, but also I think in other industries, is going more global, because the diversity of input and the diversity of thought doesn't just let us get better answers to the questions we want to solve. I think it actually goes a step farther and actually gets us better questions that we could put our effort towards to solving. And so I appreciate hearing all of your discussion, Juliana, and it's really stimulating for me to think about.
The other thing I wanted to add is we have what we call M-Pesa. Pesa is money. So the M-Pesa is the phone transfer, mobile phone transfer of money to either person or to a bank, or withdraw money, and most importantly to the hospital. For a long time, patients had to carry. Most of our patients pay out of their pocket for their health care. The insurance covers very, very little. So most patients had to carry money to the hospital. If you didn't have the cash, there was no way you will be treated, and checks were not acceptable. So now we have what we call M-Pesa transfer, where the hospitals have collaborated with the banks to have that money be transferred, so that the patient just has the phone and they are being treated. You need chest x-ray, you need CT scan, they just clicking on this and making the transfer. That has really helped us a lot. Thank you.
Thanks, Juliana. Yeah, it's certainly, from my perspective, exciting to go to Kenya, to go to other countries, to see all the thinking and innovation going on around addressing some of the ongoing challenges. And certainly I agree, Brian, that we have, the same way that we can help others to learn from us, we certainly have a lot to learn from some of the things that are going on, particularly when it comes to reaching the hardest to reach and some of the most disadvantaged. I think certainly I can give lots of examples in Kenya, as Juliana already has, of how you see that playing out in real time. And that gets into the whole issue of healthcare workers and empathy. And Brian, I hear that when the students are in London, you've had the opportunity to teach a class on the business of empathy. So I'd love to hear how you came up with a concept and what you teach and the importance you think empathy plays in healthcare and healthcare leadership.
Yeah, well, thanks for the opportunity to talk about that. I'd say I had more than the opportunity. I had the incredible privilege to teach this class with our leadership group here at Cleveland Clinic London, to teach it at Notre Dame London to the students there. And obviously being with a group like that was really invigorating. I think when you talk about empathy, one of the most important things I think to think about is healthcare. And what is it that we do in healthcare, whether it is in Kenya, whether it's in the UK, whether it's in Cleveland, no matter where it is in the US, and across the world. I think the core thing of healthcare and the absolute distinguishing fact of healthcare is that what we do is we express empathy to those in need. And that's the core of what we do. I can tell you in my 25 years as an orthopedic surgeon, I've seen this firsthand. And you see when the patient comes, what they are grasping for and in need of is empathy for their situation or for their condition. And so, to succeed in healthcare, I think we need, and we're fortunate to have the mission that we have in healthcare, but we need to continue to lead with that purpose and mission so that we continue with that empathy. And that's what actually led to that course, which I call the business of empathy, because you also have to have it be a sustainable model. So in order to be a sustainable model, there are unfortunately around the world financial constraints. And I think all countries are tackling that financial constraint of delivering healthcare, which I believe is empathy to the citizens of the country. And that kind of led to the business of empathy with that course.
Thanks, Brian. Certainly an important course. I wish I'd had that in my medical training.
And I'm sorry, but maybe, one thing I should mention also is, one of the leaders in the US and internationally actually is at Notre Dame, is Dominic Fasson, who has been, a great inspiration to me when I read his book about compassion. And it's great, I think, for Notre Dame to have a recognized leader and have a focus on this.
Yeah, thanks. Dominic actually was on the first panel from the healthcare series earlier in the month. So it was great to have him, great to hear from him. We have a few minutes to open this up just a little bit to you and Juliana. Just thinking like a decade from now, if you were to look back, I mean, it's sort of like, where do you see us going and where do you think we'll be a decade from now? What kind of changes do you think will have occurred? And yeah, it's a crystal ball sort of question. So just wondering if you and Juliana could share any thoughts you might have on what a decade from now, looking back, will look like.
Thank you, Bernard. I think we have all realized what disaster COVID-19 has done, and really everybody must be careful. And I will use this phrase: we must be our brother's keepers. Whether your brother is poor, whether your brother is rich, whether you are from which part of the country, the world is one, and you must consider to do things as one people, because everybody will be affected finally. The other thing, in the next 10 years, if we don't strengthen our training institutions, research institutions, we may not make it. The human may be extinct. We'll have dinosaurs coming back. And that is on a serious note. So we really must strengthen our research, and we must strengthen the training so that people get it right. In as much as technology is good, but I think we must also try to look at what next. If technology fails, what next? Is there something else that we can do? Can we still continue having healthcare if the technology suddenly, something drastic happens? And let's put our hands together, our minds together in the climate change. Because my friend, everywhere in the world, we are now having food insecurity. And as long as the food is not enough, there will be wars, there will be, lots of many things, and diseases will just keep on flaring up. So we must be ready as a people, not just that part of the world. Everybody must come together. The researchers must just sit together and, discuss things and find out what is the best for the humankind, not what is the best for Africa. Africa, we are still struggling with simple things, but they're still killing our children. They're killing our mothers. They're killing everybody. And do we sit there and look at how these poor Africans are suffering? Do we sit there and look at how some Southeast Asia people are suffering? I don't think we should. We should really be thinking of, we cannot be equal, that's a fact. But can we do better for the people who are less disadvantaged? So in the next 10 years, if we don't take care, we'll have more deserts. It will not just be Sahara Desert. The desert will increase. The food insecurity will increase. We'll have more people hungry. We'll have more people illiterate. We will have research not being, what it is. Can we have ethical issues being handled correctly? And lastly, let's not give room for new emerging diseases. Let's always be on the alert. Thank you.
Yeah, it's hard for me to top that. And I certainly agree with Juliana, especially, I wrote down your statement, Juliana, which is absolutely right on. Everyone must come together for what is best for humankind. And I think to that point, there's three things I think about. One of them, directly in reference to that, is I think we will see healthcare become more global over the next 10 years, and certainly over the next 25 to 50 years, to help solve the exact statement that Juliana just made. And that's certainly our effort at the Cleveland Clinic as we start this here in London. We also have a hospital in Abu Dhabi, and to gain from a more international perspective to do what is best for humankind. I think the second aspect is we will see over the next 10 years a much greater focus on the social determinants of health. And we will see that healthcare is just one aspect of a healthy community or a healthy society or healthy civilization, to the fact that 40% of the social determinants of health are socioeconomic, and that's usually jobs and education. 30% are healthy behaviors. 20% is actually the health care. So we have traditionally spent a lot of time talking about health care, but to really care about health, we need to care about the other 80%, which the last 10% is environment, which is really important. So I think we'll see a bigger focus, secondly, on social determinants of health, which is very good. And the third thing is we concentrate on population health, and we're seeing the emphasis and need for that. I think another silver lining out of the pandemic is we will see population health move more towards personal health. And so our effort as a society and as a civilization to be better globally will take individual effort on all of us. And I think the technology and science that's coming out actually allows us individually to make more of that effort for us to be healthy and not passively waiting for someone to make us healthy. So I think the three important things are going global, social determinants of health, and then population health becoming more personal health.
Thanks, Brian and Juliana. We have about 10 minutes, so we invite those of you who are with us today to fill out the form that you see in the chat function to submit a question to our panelists. So please feel free to do that. I'll start with one question which has come in directed towards Juliana from one of our previous Inspired Leadership Initiative colleagues. The question, Juliana, is much of Africa in the same COVID scenario as Kenya when it comes to late arrival medications, private hospitals, superseding the public ones, et cetera, et cetera? I mean, in other words, how does what you see in Kenya relate to similar countries in Africa?
Thank you very much, Bernard. I think it's really been handled differently by different countries, because remember, politics has played a big role on how people handle the COVID issue. So in our neighbors like Uganda, Tanzania, initially, it was following the WHO, and then suddenly, things went quiet. So I think it's so different. Once different African countries has handled the COVID situation differently. It is true, we are still having cases of COVID-19. People are still dying, but I'm happy to say that in Kenya, the mortality has reduced, the morbidity has also reduced. We are not having very more sick people as we used to have. The scare was about in the month of December. Many healthcare workers, the surgeons, the obstetricians, they all came down with COVID-19, and most of them died. So that was a scare for us. And I think the health workers went on strike in Kenya for that. So it's really, every country does it differently. But the use of the drugs, just because the way it's still not, for us, we tend to use the WHO guidelines of how to handle diseases, but the availability of the drugs is an issue. And when you are taken to private facility, you may get the drugs, whereas in the public facility, the drugs are not available. So we still have those disparity, and that affects, of course, the outcome. Thank you.
Thanks, Juliana. Brian, here's a question for you. Building a new hospital in London is quite an undertaking. What has been the most inspiring aspect of this endeavor, and what has been the most personally gratifying?
Yeah, they're probably both the same. When I moved over here, I think we had 3 or 4 people on the team. We're up to about 250 now, and we'll bring on another 800 in the next 7 months. I think the most inspiring and most gratifying has been building this team in recognizing the passion of people, and I guess at the core of their heart, the goodness in people when they realize the mission of healthcare, and for us, the mission of the Cleveland Clinic, as I previously stated about how we're trying to bring the best of Cleveland, the best of UK healthcare. And as we've gone through this pandemic, there was a concern what this pressure would do, as now we've gone completely remote working for about 51 weeks now. How that would work. And what we've found is people have dug in more. They've been more resilient. They've been more committed. They've been more hardworking as they see the need for increased healthcare capacity in the UK and specifically in London. Unfortunately, in London and the UK, there's been a devastating impact from COVID-19 and around a mortality basis and hospitalization standpoint. So the need for increased healthcare capacity has never been greater. And it's been incredibly inspiring just to see how hard our team has worked and to see the number of people that are interested in joining the team as we go out with our recruitment efforts.
Thanks, Brian. Juliana, here's a question came in for you. You had the opportunity to participate in the ILI last year, and through that process discern that you wanted to focus on your current work. I know you'll be going into that process and discussion more in a few weeks on a different ThinkND program. It's called Inspiring Conversations. But can you give us a quick overview of what you're doing now?
Oh, thank you very much. Currently, I'm in the medical school teaching the medical students, and I'm also taking them in the wards. So that I love to do that. So the students in the clinical years are the ones that I'm taking. But I'm also happy to say that the founder of the Rusalia Resource Foundation, this is an organization that takes care of disadvantaged girls, either orphans or from very poor families who have passed to go to high school and they can't afford it. Currently, we have 7 girls enrolled in the program. The COVID-19 interfered with our calendar. So our calendar for schools we were told it will normalize in 2023. So the school children in Kenya currently are in different trimesters, and that is bringing a problem. These, well, as when I was growing up, really, some people paid for me school fees, tuition, took me to school, bought for me a few things. So I just decided it's good to give back to the community. So that's what I'm doing. So when I was in the Notre Dame, I have a few friends that are also supporting me on this. The foundation is also registered in the South Bend. And I'm very happy that we have a board that is very active. And here in Kenya too is registered. And we hope in the next few years, we'll have more than 100 girls to go into school and completing. The problem I have in our city, Kisumu, Western Kenya, teenage pregnancy and girls dropping out of school is very high. So apart from just the tuition, I'm also embarking on the mentorship program. Mentorship and kind of being a mother, not too much of a mother hanging around the girls, but a mother and mentoring them, trying to, tell them there's a time for everything. The time will come. So that we reduce the teenage pregnancy and the school dropout, and the girls will complete school so that they can go for further training, or they may have other ventures in life, but more learned. So that's what I'm doing currently. Thank you.
Yeah, thanks. We have lots of questions coming in now, but we have time for maybe one more. So Brian, this is, since you're in the UK, this is a query that's coming in from Dublin. What specific technological innovations do you feel will best facilitate the move from population health to personal health over the next 10 years?
Well, I think a lot about data collection, a lot of the devices that are available for individuals to wear to get their personal data. Some of that transferred to the physician or to the healthcare system. And I think as we go to the future too, we're going to see new definitions of what the workforce is. So I think in the next 10 to 20 years, you know, the healthcare worker today will be different than the healthcare worker of tomorrow, not losing the core of empathy, however. And so what we'll see is people who can be available to help with interpretation of many of these wearable devices, many of these things that can be done remotely. You know, there's going to be an unprecedented scientific knowledge explosion, unparalleled diagnostic and treatment capabilities that will become available. And what I'm excited about is I think we'll see that the science of medicine will be handled more technologically. The art of medicine, which is empathy, will now have more time and will relieve these caregivers of the future much of that burden of collection, analysis, and reporting of data, so that we can capitalize on the science of medicine to enhance empathy, and therefore, you know, as I might have mentioned before, to unlock the meaning and purpose in the work of healthcare providers, which is what we need so that we can drive more meaning and purpose and reduce burnout and get more people interested in what is an incredibly privileged career and profession to be a part of.
Yeah, thanks, Brian and Juliana. We're running out of time now, which is unfortunate because I think we could easily continue this for and impose on your time for another hour or so. But given the fact that we're wrapping up now, I really want to thank all of you online who joined us today. And if you've missed any of these sessions, you can find the recordings on ThinkND. So please feel free to share this series with your friends. We'll take a few weeks off and then reconvene to explore where we're going in education. I'd also like to especially invite you to the Inspiring Conversations series on ThinkND, since Juliana will be participating in that program on March 9th to discuss her leadership experience and share more about the inspiring work she's doing now as part of the foundation. So please register for that series through the link we're sharing with you now. Again, Juliana and Brian, it's great. Thanks for your time. I look forward to our paths continuing to cross. And certainly Brian and Juliana, when you're back here in South Bend and on campus, let us know. I'm sure, hopefully there'll be a time where we can get together without masks and raise a glass at something. So thanks, everyone.
Thank
Thank
you.
you.
Juliana and Brian, thanks. It was fabulous.
Thank you.
Thank you. Nice meeting you, Brian.
Nice meeting you too, Juliana.
Yeah, thanks.